welcome everybody to the Cheshire and Merseyside Health Protection Continuing Professional Development event. I'm Thara Raj, Director of Public Health for Warrington, and I'm here on behalf of all the Directors of Public Health in Cheshire and Merseyside, and delighted to put this event on with the CHAMPS team. We've got some fantastic speakers, some great workshops. I just wanted to clarify the strategic objective of this CPD event. What we're trying to do is put a magnifying glass towards Cheshire and Merseyside Health Protection. We realise we've got people from the North West as well, and we'd like you to help us with that endeavour. We will have, after the speakers, we will have a Q&A session, but Professor Dame Jenny Harries may get called away to a very interesting call, so we need to just give her some time to address any questions immediately in case that happens. Absolutely delighted that we've got our consultant public health protection leads who are going to be facilitating some of the sessions with others from UKHSA. We're considering having a call to action potentially at the end of the session, towards the end of the session, but we'll talk to you a bit more about that. Without further ado, we're going to have a couple of breaks. I'll go through a few quick housekeeping rules. Essentially, the chat function will be active, but the speakers will have theirs muted, and you can feel free to do that yourself. We're going to be using the hashtag, and it's going to be in the chat. It's hashtag protecting communities, big P, big C. You will have a bit of time for a comfort break, as I said, and the session will be recorded. We will try and share some brief notes following the meeting as well. And we're just finalising permissions to share these speaker presentations with you. All right, I'm going to hand over now to Dr. Sam Ghebrehewet. Thanks.
Thank you, Tara. Thank you very much. Can you hear me? Yeah, thank you. It's really nice to see a good turnout today for our first CPD event since the pandemic, which is great. And I will also want to extend my warm welcome to all of you, including Professor Dame Jenny Harries and Fiona as well. To start with, I think I'm really pleased and honoured to welcome and introduce Professor Dame Jenny Harries to our first Cheshire Merseyside HPD Health Protection CPD event since the pandemic, since the beginning of January 2020. Jenny is the first Chief Executive of the UK Health Security Agency, an executive agency of the Department of Health and Social Care established in October 2021. So just a brief kind of background to Jenny. Jenny is a medic by background, and her first degree is from Birmingham University, UK. She undertook her specialist training in public health medicine in Wales. Jenny has a wide experience of clinical and public health science and practice, as well as health service commissioning from her work in the NHS and local, regional and national government. I think as we all have experienced Jenny's kind of interaction, having played central role in case response to a number of significant health incidents. I think those of us in public health and health protection will remember her contribution in Ebola, Zika, MERS, Novichok attack in Salisbury. Who will forget that? And she was appointed a Deputy Chief Medical Officer for England in July 2019 and served through the COVID pandemic until taking her present role. Jenny has also previously served in the JCVI, Joint Committee for Vaccination and Immunization, the Expert Advisory Group on NHS Constitution, and Jenny has worked in policy evaluation clinical roles in many other countries, including Pakistan, India, Brazil, and New Zealand. In addition to her medical degree, Jenny also holds formal qualification in pharmacology, business administration, health economics, and strategic health service planning. So that is a long version. I think I have tried to manage it in a very short kind of brief, but extensive experience at local, regional, national, and international. So without further ado, I will hand over to Jenny for her presentation in UKHSA plans and priorities. Over to you, Jenny. Thank you.
Thank you very much, Sam. That actually, you often, when people are introducing you, you start to think, is that really you? But of course, behind that is not just my work, but everybody else's as well. And it doesn't seem that long ago when I was the regional director in the south of England and Thara was in my patch. So I think hopefully it feels more like a family of public health and health protection personnel. And I'm absolutely delighted to be here. Colleagues online may be quite pleased. I have only 10 slides. They're quite high level, and that is intentional because I often find that the benefit I bring is actually allowing people to ask me questions so that I can focus on the things that are important to you rather than the other way around. And I think that is exactly how it should be, having worked in local authorities myself in Wales and in England, to make sure, as we've seen in the pandemic, that we listen and are fully aware of what is happening on the ground, because at the end of the day, we are here to protect individuals, to protect families in their communities. You know, it doesn't perhaps always come out that way, but when I'm planning at national level and holding high-level discussions, I may, even if I don't actually say it in front of ministers all the time, my starting point is, if I was the DPH back in my old job in Norwich, for example, in Norfolk, how would this suggestion feel? You know, would it be okay? Could I see my poorest communities in Great Yarmouth or wherever it is actually benefiting? Would they be protected from these decisions? So I do try and bring that role right into central government, and it is in fact why I worked my way through the ladder, if you like, completely unintentionally, in order to make sure that sensible things got decided to make sure we can protect people on the ground in our communities. So I was asked just to talk about national plans, priorities and policy updates, and then a little bit about the new structures for health protection and ways of working with the regions, but then also a UKHS view of how local authorities can best contribute to the system. But actually, I think that should be the other way around, is I ask you how you think we can help you best contribute to the system and make sure that that works. But just to kick off, we've just had our very first birthday as a new organisation. So obviously we are an organisation born in the pandemic, from the pandemic. So we do start off with that focus. It was given to us. It is actually a very responsible task, but it's also, I think, the best job in the UK, because we have a really, really simple mission, which is we're making the nation health secure. Now, we didn't choose the name, the UK Health Security Agency, and my immediate reaction was, okay, if I turn up with a black jacket and a big branded government sign-on, and I said, I'm from the Health Security Agency, that is really not going to reach out to many of the communities that we most want to support with health protection measures. So I tend to use the health secure element for communities to ensure we are trying to keep communities safe. But we also do have a key role in national security now, which I will come on to. So as you can see, what we actually want to do, we want everyone to live in a world that's secure. So there is a signal here that the work that we do reaches right from an individual family, an individual community, right across the country. It does include work with the devolved administrations as well. The UK title is there. We work with them if it's for their health systems, and we work for them if it's a non-devolved matter of health. So, for example, security. And one of the things that I know you will know is it doesn't matter if we are getting into a living with COVID space, there will be new health threats coming through. The health threats are constantly emerging. We've seen that with monkeypox in the last while. It's not that we didn't know about it, but it's now being transmitted in a very different way. So for us, this is an ongoing responsibility, but we are very much a health protection, health security agency. So if I just move backwards, obviously with the changes, the Public Health England was the capacity and the skill set there has been divided, and I'll come back to that because it's an important point that we need to maintain the connections. And so OHID now, the Office for Health Improvement and Disparities, is within the Department of Health, overseen ultimately by the Chief Medical Officer, and then the health protection elements have moved to the UK Health Security Agency. And the way I describe the organisation is twofold, and they're not either or, they're mutually required. One is, if you like, as the health insurance, health protection insurance element for the country, but we also have a really strong scientific growth agenda, so contributing to the growth of the economy and to life sciences through our work, particularly on vaccine evaluation and scientific endeavour. So I'm going to use my famous next slide, please. If you look on the web at the moment, you will not find a UKHSA strategy, which is a little unfortunate because I'd like to share one with you, but because we are in some interesting political times at the moment, because we're a very new organisation, we haven't yet been able to publish that, but we do have high-level goals, and sitting beneath this, which you will see in due course when things get signed off, you will find some much more discrete objectives, which will be ranging from things like supporting increases in primary childhood vaccination rates to having particular focus on bloodborne viruses, hepatitis C, harmful impact elimination, for example. So those will come through in the future. But the critical goals that we've set are about being ready, being prepared for future health security hazards, so protecting against those ones that we know, but equally new mechanisms for horizon scanning, changes in the way that we do surveillance, and some of that actually builds into the security system. And then, so being ready, being prepared. The middle one here, responding, and obviously that's the one which Sam particularly and local authorities, we work together on to save lives and reduce harm through effective health security response. And that isn't just about infectious disease. One of the things in picking up the reins of the Health Security Agency is to really bring forward acknowledgement of the risks of other external health hazards. So we need to keep the great work on infectious disease, but we need to make sure people understand the health harms and the protections that we can support for climate change, for significant external weather events, for large mass gatherings, for radiation and chemical events. And so that's an area which we are proactively buffering and building as we go forward, which brings me nicely on to the third big goal, which is about building the UK's health security capacity. And that isn't just building it in the UK, actually. It is about supporting the building of public health capacity abroad as well. And we have a number of programmes running under the international health regulations, because we know that to keep the UK safe, actually other countries need support to keep themselves safe as well. And so we do have a global reach in trying to do that. I think that last bracket is an area where I'm very confident I may well get some questions in due course, because I think one of the issues here is we have seen over time that the capacity, both in local authorities and in local health protection teams, had dropped off prior to the pandemic. I know we looked at our, and I won't go into the detail of funding, but we looked at our funding and could see that there was a over 40% drop in funding from 2013, when Public Health England came into being, until when we were sorting through the SR settlement just before our budget was announced. And so, although Sam may not quite be feeling it yet because we're downsizing a lot of the non-substantive posts, my aim is to make sure that we have a bigger, stable workforce, and that we use that workforce. It's not just a UKHSA thing, it's a workforce there for communities and to support local authorities as well. So the other part of the building capacity, though, is that second prong I was talking about, which is contributing to the strength in life science and working with industry. Now, clearly, we have to do that very carefully because there are governance issues. We also support the JCVI. We work with Medicine Healthcare Regulatory Authority. But this is really very critical to enable the variants of vaccine mission. So being able to spot a new variant and help develop a new vaccine in 100 days, which was the mission announced at G7. And so getting this scientific endeavour, getting the connections and minimising time that you need whilst keeping all the right robustness of decision making in is important. And then right at the bottom of this slide, it's sitting there as a narrow line, but actually it is critical. And I suspect it's where we overlap most of all with the work of local authorities, which is about achieving more equitable outcomes. Now, although under the new health, public health arrangements, if you like, the health improvement side of things has gone to the Department of Health, we have been absolutely clear from the start that everything we do should address achieving more equitable outcomes, whether it's reaching out to communities to ensure that they understand risks, that they know what they can do to help themselves, whether it's when we're looking at our data, we make sure we have those variables recorded to be able to cut the data and analyse it. And then when we're looking at outcomes to see, are we actually having an impact to improve outcomes right across the patch, but really focused on getting equitable outcomes. Next slide, please. So this goes over a little bit of what I've said already in a way, which is why are we here? Well, learning from the global pandemic, which is exactly what your event is about, but recognising there are new and growing risks. And the summer period where we've had hot weather, so the 40.3 degrees in Coningsby in Lincolnshire as a world record, as a UK record this summer, I think has really brought home to the public and to politicians just how important this is. This is no longer, it's a pleasant summer trip and it's getting a little bit warmer when we go on our summer holidays. Some of the scenes from wildfires were quite apocalyptic. And then when you translate that through to things like how our hospitals function, the impact particularly on the elderly and the very young, this becomes a very significant health risk. So there's a big opportunity here to communicate, but to do that in a way which really saves lives. And I think one of the things we do, which I'll show on the last slide, I hope, is about coordinating expertise and skills across the system. At the end of the day, somebody with an infectious disease is sitting in a community, and that will be sitting with local authorities. But what we can do is work with you to support you through the expertise. And Sam, for example, can reach into some of the world's best, real experts in some of these diseases at some of our national centres in UKHSA. Just flag at the bottom, obviously, so again, the maximising the social and economic impact of health security goes to reducing health inequalities. But also, one of the things we're striving to do in some of the ways we're reorganising is to get operational agility and flexibility. So absolutely the proportionate response. If it's something that needs urgency, we have world-class systems that do that. And I know Sam and colleagues have been involved through the Health Protection Operations team in getting those going, and that process is still working through. Next slide, please. So probably mention most of these in terms of the future of UKHSA. The four things on the left are what we're really striving to be. So a driver of world-class health science and innovation, very much around things like vaccine development and the new tests. We've seen lateral flow tests, being ready to generate that sort of thing if we have a new disease coming through. To be a global leader in health security, so working with the Foreign Office, working with the Department of Health. And then the next one down, a clear role in national security. Now, this is very new. What it means is that the agency is now sitting as one of the key organisations to support health security or support national security through the health agenda. And what the pandemic has done is really flagged how important health is, both to obviously the sustainability of life just directly, but then the impact that it can have on the stability of a country in terms of its economic position. And then last but not least, being a system leader for health emergency planning and response. And of course, that's the bit we cannot do alone. It's the bit that we need to do with you. Next slide, please. So this is just a quick slide saying broadly what the older health protection system would be, but I just wanted to flag our NHS partners on this one, which I haven't spoken to before, because I think you've got some sessions coming up, but ICBs, I think, are whilst there will be challenges at the moment, I'm sure, in the setup, the opportunities there are huge for working together and across the agenda of health protection and health and wellbeing generally. And a resilient population in its health will be a resilient population to many of the health protection issues that we are dealing with day to day from UKHSA. But I think that broadly is the health protection system before. And then if we go on to the next slide, you'll see that in many ways it hasn't changed. These are our, I don't know whether some people will call them customers. It depends which mode we're in. Are we talking to business or are we talking to communities? But they're our stakeholders. They're the people we work with. And it's vast, actually. When I'm sitting looking at my diary, I'm oscillating 1 minute between a Royal College, somebody from the WHO, and then an individual member of the public who wants to know something. And I mean, it's one of the joys of the job in many ways, but it does make it quite complex. And it's very easy for different organisations to feel left out. And one of my jobs is to make sure I try and continue to communicate with all of these groups. Some of the ones that are really important, I mean, at the bottom, I've put members of the public actually at the top of that regional and local list, because we all know that actually the public have been, without the public, we can't do health protection. It's public health protection, but actually they got really good at it. So the dashboard, the COVID dashboard, which we produced, has had, I think one day it had 72 million hits, I was told. It's been one of the most successful, highest hitters on the web for many months through the pandemic. But the reality is, it almost got to the stage of it didn't really matter what we said, because the public were watching the data in the last couple of waves. And as the waves started rising, they were taking appropriate action, and the waves were starting to flatten off and come down again. So it's a much more alert public, I think, to health protection issues. And I would like to think we can help that happen for other infections and external hazards as well. But then, of course, other areas where it's very important for the work we're doing, university partnerships and research as well, because in preparing for future pandemics, what we're trying to do is make sure that those systems are set up and we have regular communication, regular meetings in peacetime now, so that we can rise them up very rapidly and learn from the pandemic. And then, of course, we want to be influencing and contributing what knowledge we have to global institutions, so working with other health protection agencies, but also with the national institutions for public health as well across the world. Next slide, please. I think if you keep pressing, you'll hopefully, a little colour box will pop up. That's very good. There we go. I was just about to wonder what that was. So I think if you keep pressing around, you'll find that there are some main groups here, which are broadly the ones that we've outlined. But as I say, always putting communities and members of the public at the top. But of course, we are also very close to government. Technically, I'm the second permanent secretary in the Department of Health, and yet I'm leading as a registered professional, an arm's length body which has some autonomy and independence in what it does. So that's both a difficult line at times, but it's a very privileged one as well. And then the other parts of the system which we've just discussed. And then I think there's probably one last slide on monkeypox. And really the key word on this one is enables. There's a very busy slide, and it just runs through broadly what happened in the monkeypox outbreak this time, running from unusual rashes noticed by clinicians in the healthcare system, the fact that the samples went to the UKHSA's rare and imported pathogen lab, important down, Ripple, that triggered a response in the high consequence infectious diseases network, which is a system set up and expanded particularly after the West African Ebola outbreak in 2014. So good evidence of learning from that. And then moving down to 3 at the bottom on the left, all of the concurrent engagement that has to happen. And that goes right from speaking to you in communities to make sure we're finding all of those individuals, right up to formal requirements to announce the fines under international health regulations, and then obviously on to communications and wider population awareness. And if you look on the right hand side, huge numbers of different groups, and in this case really critical that we've had different groups. So BASH particularly have been absolutely superb in supporting the response, and most of the communications that have gone out for this particular incident have not come with a UKHSA security badge on intentionally. They have gone out through different social media, through other forms of communication, through the relevant active groups supporting MSM. So I think that was the last slide. I hope the next one just says questions, but it should set the scene. Very happy to answer any questions. I am hoping to stay on at the end, Thara, if we're running a bit short on time now.
Many thanks, Jenny. A really helpful oversight. I think one of the questions that that was on my mind, Andy Turner has put in the chat. So to paraphrase Andy's point, is there anything that we're doing now that the PHE family didn't do? And what are the opportunities that we can support? What are the advantages, etc.?
So we as an organisation are definitely doing things very differently on the science side. So I do think historically, when PHE was born, it was brilliant at working with local authorities, I think, but possibly some of the health protection and science side dropped off the agenda a bit. And so what I think is, on the one hand, COVID and the start of UKHSA and the roles of DCPH have absolutely come to the forefront. So there's an awakening in both, in the public, I'm sure in your local councillors as well, in politicians nationally, just how important public health is. As an organisation, we are definitely proactively growing our science agenda. Now, that might seem quite a long way from the front line of the work that you do, but if we think about where we are now, the vaccination programme has been so important, and we feel that if we can do that and we can get ready, and there's lots of work that we can do, working in a different way. As I say, I'm very mindful it needs to be appropriately governance, but actually working with pharmaceutical industries to do the horizon scanning, so we can in some ways say, actually, these are the diseases, whether they be new or actually ones that we haven't really tackled, that we think have an impact on the public's health. Can you help develop this? We can work with them in a much more consistent way. It reduces their risks in developing vaccines and countermeasures because they know we're seeking it for population benefit, and we can help support the appropriate development and make sure that we're addressing those with the biggest public health negative impact. So I think that element of science, but even things like developing tests. So, lateral flow tests have had quite a bumpy journey through this, but the reality is, if we have a significant surge now, we are much more likely to go out with a lateral flow to understand population movements. It's much easier for the public. And we can still do the specialised studies on the genomics from PCR samples, but that is a new thing that we didn't have before, and we could develop it earlier for the next one. So a long way around is saying we're definitely growing the science stuff, but don't think that it's kind of really techie stuff that we do here. It's for the benefit of everybody, so that we've got tools available to reach to the public.
Perfect. And I think that really dovetails nicely with Elspeth's point about the role of local authorities in helping to build that research base. We are public health professionals with R&D, it's part of our DNA. So I think that is very much a strength of what we can achieve together. So it would be really helpful for those collaborations to happen together, but from a grassroots perspective. I think that's the point that probably Elspeth and others are keen to do. I'm just going to take a different tack, Jenny. So chair's privilege. We've got the National COVID Inquiry with very tight deadlines. Understandably, people need answers. But and I'm really glad that ADPH are collaborators, the BMA, LGA, etc., etc. The biggest risk, as we all know, in health protection is communications, and I'm finding it personally quite busy as to the evidence to prepare is the evidence. You can't prepare the evidence. You just have to make sure you can get hold of it and catalogue it. It's just the channels. It confused me ever so slightly. I'm guessing it does for others, and I'm wondering, how we can make it a bit easier. I know that there are meetings happening between the collaborators, but I think it's, given that it's about to be Christmas, just wanted to feed that back. Probably isn't a question, really. And no, you're probably feeling the same as well.
Well, Thara, no, I mean, in some ways to commiserate, I mean, it's really important that the public inquiry happens. I think, it's what the public expects, and I think we have a responsibility, and it's right. We should be actively seeking to learn from events. I think it is important that, how it gets communicated, not just formally, but actually by the media, is going to be really important. And I do think it may be challenging for many of our staff, and I am very mindful of that. Where people have worked all the way through the pandemic, it's very easy for somebody just addressing this cold now not to understand how much pressure people were under at the time decisions were being made, or the pace with which they were working in almost all sectors of response. I mean, I didn't see anybody in the pandemic, in any set of circumstances, in any organisation, who wasn't just trying to do the best for the public and their patients. And I think that's an important point. Your point about it is quite difficult on the because the formal arrangements for the inquiry mean that in many cases one is not allowed to collaborate. It has to be a statement of our own, and we're actually just grappling with that ourselves at the moment. And personally, I'm bracing myself for next year, because I have to carry about 5 different hats because of the roles that I've played in. I look back, and it turns out that I think I even drafted, as a senior registrar, the pandemic preparedness plan in Wales, right at the start, something that was still around in 2009. And so I'm going to find myself arguing against myself, depending on which hat I'm wearing at an inquiry. So I think the only thing I can say is, well, obviously, if we can help in any way, we will. I think it's a huge task for everybody, and I think we're all we've just had a 2 Rule 9s come in, and the timeframes are really challenging. At the end of the day, we have to maintain the health protection of our populations, even when that is going on. And I think many people are explaining that to public inquiry officials as well.
Thank you. I'm not going to go through all of the questions, but some of the ones that are flashing up there's one from Charlotte. Form follows function. How can Cheshire and Merseyside establish what health protection functions will be fulfilled by UKHSA, local health protection team, and which functions can be fulfilled by the local authority public health team?
Yeah, and that was a question I was expecting. And I think actually it's the one that when we came we haven't come to the end of the pandemic, let's make that absolutely clear, but when we came out of the sort of acute phase and realised that our vaccines are working pretty well, almost slightly regardless of variant, you start thinking, well, what have we learned? What can we do? What worked really well? And what worked well was everybody was working across the system. And there is a piece of work which we kicked off straight away, working with ASDPH, CIEH, various different LGA, to actually try and establish, if you like, the roles and responsibilities. So forget the money, forget the resources, it's exactly that question. Let's not get sidetracked by that, but just say functionally, what were the things that we know work best in one place or another? How can we get that system to work and always pick up when it needs to and drop back again when it doesn't? And that piece of work is extant, it is still ongoing. And I'm being entirely honest, it set off at huge pace and it was wonderful. And then we had quite a rocky ride and now it's back on track again. And I think we should just expect that. It's not easy to do, and then there are the real questions about capacity. But I think if we do that piece of work, it lends evidence, if you like, objective evidence for us to then start moving bits of resource around, or for different parts of the system to flag where there are capacity issues. So that piece of work is ongoing, and hopefully, will get concluded in the next few months.
Thanks, Jenny. I'm not sure if there is an answer to this, but can you comment? So it's Terry's question. Can you comment on the emerging thinking, or if, how, when UKHSA may trigger from the local authority a contact tracing type of incident?
Yeah, so I'm not going to answer it directly. I'm just going to step back a few spaces from that. So what we've seen, I think, during the pandemic is there was a contact tracing system. Not everybody in the political world knew about that to start with, so we ended up with two, three, if you like, because obviously local authorities already do that work as well. Health protection teams do, and then we ended up with test and trace. Now, none of those systems independently would have been sufficient to manage what we had, and I think we just recognise that and say, what do we need for the future? And at the pace and size of the pandemic, I don't, UKHSA on its own with its health protection teams, local authorities could not manage it, but equally, local first and understanding local communities is usually a much better way of managing infection controls. So as we go forward, the trick is, I think, to be able to flex that system across. And for us, so I think having a trigger is a bit difficult to say. It wouldn't be at a particular rate. It's going to be depending on the circumstances in a local area. What we're trying to do, and have to some extent used already for monkeypox, I call it having an elastic system. So although we've downsized the test and trace nationally, we do now have, used for monkeypox, a system which says, yes, we can put in a larger telephone type system to respond to bigger incidents. And we're still working through these. And internally, I've set up one of our groups. You can look at our organogram for senior people on the web. One of the groups is health protection operations. And the whole purpose of that group is to make sure that all the action that happens, where we've got incidents running, that we have, where it's appropriate, standard operating procedures, that they just go like clockwork, a bit like the army, that it goes like that. But actually part of that is, how does the testing and tracing bit step up when more support is needed across the nation? How does it step back down again and ensure that it stays with local authorities and with local health protection teams? So again, it's not perfectly formed at the moment, and that is the last grouping really, which we're sorting out, and we still need to appoint to a leader. So hopefully you'll see a little bit more work. I'm really keen to engage with you to make sure it works practically, not just that it's a dreamed up idea at the centre of government.
I think you've handled all your questions admirably. So many thanks, Jenny. I hope you can stay, but I understand there is something pressing. So many thanks on behalf of all of us. And you have actually segued very nicely into Fiona's section, because Fiona, I think, has been understanding some of the pieces of the jigsaw. So I'd like to introduce Dr Fiona Lemmens. Fiona has been a practicing GP in North Liverpool for 25 years. She's a member of Liverpool CCG governing body from 2013 until 2022, and was the chair of the CCG from 2018 until 2022. During Fiona's time at the CCG, she led on urgent care, system transformation, and throughout the P word was the clinical lead for Liverpool's vaccination programme. She's now taken up a role as Associate Medical Director for Transformation at the Cheshire Merseyside Integrated Care Board, Stroke Partnership, and she also acts as a Deputy to the Exec Medical Director, now with the SRO and Strategic Clinical Lead for CNM COVID Vaccine Programme. Welcome, Fiona. I think what I would say about you, Fiona, is you're an active listener and you're really good at offering support and resources. So over to you.
That's a very kind introduction, Thara. Thank you very much. So you can just flick on to the next slide. Thanks, Barbara. What I was asked to talk to you all about today, and it's very nice to be here, thank you for asking me, was about the challenges that the ICB faces, and also the challenges that I face personally in protecting the health of our Cheshire and Merseyside population. So I could have gone on for a lot longer than my 10 minutes, but I picked out 7 that I thought were hopefully relevant to the audience today. So I'll go through them now. Next slide, please. The figures on this slide talk for themselves, really. We are either the 2nd or 3rd biggest ICS in the country, depending on whether you look at our geographical size or our population. But either way, we are up there. We are really big. It takes more than 2 hours, I think, to drive from the top to the bottom of our system, which is a challenge. But then when you look at the complexity of the number of providers and all the points of communication that we have to work with, communication is a huge challenge for us. Next slide, please. I think this is possibly our biggest challenge that we have, is how do we protect the health of and support the people who live in the bottom right picture of lovely Cheshire countryside, and how do we do that at the same time as looking after the people who live in some of the most deprived parts of the country, let alone Cheshire and Merseyside, in Knowsley and in Liverpool in particular. And that the distribution of our deprivation is a real challenge for us, because, next slide please, Cheshire has pockets of deprivation as well, and rurality brings its own challenges, particularly for health protection. So someone was talking to me recently about the avian flu outbreak in Cheshire, and you know, so I think for an organisation that's responsible for the health of that entire population, these are really significant challenges. Next slide. If you just pause it there, Barbara. The expectations of the ICB are really, really significant. I started in March in this role, and I'm aware of the growing expectations. And then on the 1st of July, everybody went, ta-da, new ICB, everything's going to be great, everything's in place. But the reality is that we are still very much building our relationships, setting up our governance structures. We are going through a massive staff reorganisation, which is hugely disruptive. So you can carry on, Barbara, thank you. I'm sure some of you have felt the impact of the fact that the ICB is not yet quite fully functioning. And so a big request for your patience with us as we get our house in order. Next slide, please. I think there's a lot of uncertainty about how the new world is going to work. We've got these new things called places and neighbourhoods and systems. We've got the ICB and we've got NHS England / Improvement, who are also going through their own internal reconfigurations. And I think there is uncertainty about who's doing what, and I think that was referred to in the last bit of the discussion as well. So it's reassuring it's not just in health, but in health protection as well, that there are those questions. I think an example here would be the COVID vaccination programme, that we still don't know what the long-term plans are for the operating model of the COVID vaccination programme. We're still waiting to hear what NHS England want us to do, but we have got staff on fixed term contracts that are looking to go and work elsewhere if they don't know what we're going to do. And I think, Emma, you put in the chat about the childhood IMS programme. I think that is another question. the services that are, what services are coming from NHS England into the ICB. So lots and lots of uncertainty. Next slide. I think our ongoing challenge is that COVID is still here. Our systems and hospitals are still feeling the pressure from it. And we are still in the midst of a significant vaccination programme that we've kind of all got so used to delivering that we, I think, have I've maybe lost sight of what an amazing job we're doing for the scale of it. And so anyone who's been involved in that, it's a massive thank you and a well done on that. Next slide. I wasn't going to say a huge amount about finances, but it is a significant issue for us in health and in local government and at the interface in between. Cheshire and Merseyside are already this year hitting a £45 million deficit, which has us on the naughty step with NHS England. And that significantly restrains our ability to innovate. It doesn't stop us trying, though, doing things differently with the resources that we do have, but we do have to be realistic about what we can achieve here. And it does worry me slightly, some of the cost improvement programmes that some of our providers are faced with are quite unrealistic and present them with significant challenges. And we all know that when systems are under pressure, it's the proactive prevention stuff that gets lost because we all fight the fires and look at what's urgent instead of what's important. Next slide. But there are positives and opportunities, so I'll talk briefly about them. Next slide, please. Just a big up to our Champs Public Health colleagues. I think, I don't know where we'd be on Cheshire and Merseyside if you guys hadn't been such early adopters of that collaborative approach. And it's put us in a really, really strong position. So thank you for that, and it's a real positive. Next slide. We have an opportunity to work differently. These pictures, I just love these pictures because the one up that this is the bus that we did in Liverpool, but you know, there is a bus driver in that picture, there's a doctor, there's a public health person, there's nurses, there's a GP, there are people who are patients of mine who volunteered on the bus. So that opportunity for us to do things differently now is really, really significant, I think. We need to maximise that. Next slide. And so we are doing so. We need to continue what we learned, that we took services out to communities during the pandemic, and we have continued that. This is a picture of our Cheshire and Merseyside Living Well bus, which now tours the area, doing COVID vaccinations, but also making every contact count, because they will do blood pressures, they will do point of care, cholesterol, they'll give health advice as well. And this is the new way of working that we need to adopt. Next slide. We've got a massive opportunity to work on sustainability together across Cheshire and Merseyside, and I just wanted to sort of flag that rather than talk about it. So next slide. This is one for our new health secretary. It was the most simple explanation of why we don't share our medicines that I could find. But this is an opportunity for us now that we have a single strategic commissioner across Cheshire and Merseyside. We can scale up instead of, it sounds a little derogatory, but to say tinkering in CCG areas on antimicrobial resistance, we can do something across the patch that I think will be much better. Next. And this is our other huge opportunity, is how we integrate at place. And I'm not just talking about, we need to integrate our service level provision, so our district nurses working alongside our social workers and our social care providers, but also at board level and with our health and care partnership, but at every level, the ability for the NHS to work with local government collectively, but also at individual borough level is something that we really have to maximise. Next. And finally, huge opportunity. We have never really grasped the opportunities that working with our higher education institutes have offered us in the past. And this is something that I know Rowan Pritchard-Jones, who is our Exec Medical Director, is very passionate about, the fact that we have to maximise these opportunities going forward. I think that might be the last one. Thank you.
Well done. You landed as well, Fiona. Thank you. I'm going to ask, because you've certainly thrown up quite a lot of questions, but I'm going to go straight to Sam, if that's all right, and say we'll pick up some in the Q&A.
That's fine.
Good.
Thank you.
Great. How do I introduce Dr. Sam Ghebrehewet in 2 minutes? So, Sam, since 2001, has been working as a consultant in communicable disease control in the North West. He's held a lot of different roles, including the unit director for Cheshire and Wirral, the director of C&M Health Protection Unit, the deputy director of Health Protection for C&M in PHE, and interim regional deputy director of Health Protection for UKHSA North West. Since 2013, Sam has led on a number of health protection programmes for Cheshire and Merseyside, North West and national, including being the vaccines lead for Cheshire and Merseyside and North West, the AMR lead, very importantly for C&M, since 2013, and various other roles. I think the one that I wanted to sort of point out was it is very much linked with the work that Jenny mentioned. So being part of UKHSA and PHE and Health Protection Agency and all the bits that went before, you end up doing international, local, regional, community all in the same day. And I think that's what Sam has had to juggle. He has published over 30 papers in peer-reviewed journals. One of the most exciting things that I've read in health protection has Sam's and other people's names on it, Health Protection Principles and Practice. He didn't ask me to plug that, but I do think it's a great read. There are very many awards that Sam has received over the years. The most recent one is the Faculty of Public Health President's Medal for Outstanding Services to Health Protection. So, Sam, over to you, please.
Thank you. Thanks, Thara. You're embarrassing me. I think it's all collective achievement. I would say the whole family of public health in the Northwest and everyone else. Just to start as well by thanking everyone. I think massive thank you to everyone for amazing work we all have done during the pandemic. All UKHSA Health Protection teams, OHID staff, CHAMPS staff, local authority public health, wider local council staff, NHS staff, academic colleagues, and other our organizations and partners. I think that is really, really important contribution to the way we responded to this pandemic. So we just wanted to say we are indebted forever for what they have done and your significant contribution. I think this is the first kind of big audience we have since the pandemic. So thank you. So that is the first kind of acknowledgement. I think Fiona said it, and obviously Jenny has said it several times, even in writing and also in her weekly kind of communication with staff and everyone else. So thank you. And at the UKHSA conference recently as well. Obviously, the pandemic is still with us, hasn't gone away, so that contribution still continues to this day. And obviously, I can see the chat as well. There are a few questions related to the COVID pandemic currently. So going back to my presentation, thanks, Jenny, for excellent overview, because I have only focused on Northwest and kind of local arrangements, which is going to be really helpful. So I was going to focus on operational issues in the main, and obviously Fiona has touched on the NHS side as well, which is great. Just put there Mirav Kleiner, who is job sharing with me, the Regional Deputy Director for Health Protection, and Wendy Shepherd, who is our Head of Health Protection for Cheshire Merseyside, currently seconded to the Emerging Infections and Zoonosis at the national with the national team. So that is great. And obviously, I hope Will Welfare is with us as well, Director of Operations, our own Northwest contribution to the national team. So we have got quite a strong training program in the Northwest, and we have produced quite a lot of key people supporting, obviously, PHE and now UKHSA. Okay, next slide, Barbara. So I put these three kind of key UKHSA remit letter. I think Jenny covered them quite in detail. And if I can pitch Jenny's kind of very key pointers on this at the UKHSA conference, prepare, respond, and build. I think that is easy to remember. And so all these three, there is inequalities and communication going across all of them at local, regional, and national. So reduce harmful infectious disease and other health security hazards. That is, if you like, prepare and prevent. Prepare for future health security hazards, that's preparedness, so that our health, society, public health service, and the economy are less impacted, and strengthen health security capabilities, that is the build aspect of it. So really easy to remember using prepare, respond, and build. Next slide, Barbara, thank you. So I tried to focus on what is at local level, what kind of services are we delivering, and what is on offer in terms of health protection. So what I have put here is just the visible ones and the ones that are easily understood and we can remember, but I kind of acknowledge there are a lot of functions that are delivered at local level, maybe not included in this. So I can start with the UK Health Security Agency, and obviously health protection response, a specialist input from local to national, surveillance and epidemiology, and health protection programs leadership at local level. So they are just kind of some of the key ones to mention. And if we move to local authorities, public health, I think the ones most visible are community infection control nurse and environmental health officers, which are under a caution, I think, in terms of resources. Assurance role, I think we have seen that is more than that during COVID pandemic. And local response support, and again, that is undermining the support because it was shared responsibilities that we have done during COVID. And in between, I have put kind of jointly done local networks and stakeholder relationship. And as Fiona mentioned, CHAMPS has been great pre-COVID and during COVID in facilitating that. Strategic development of local systems, we do this jointly, and communications. So there are other areas in terms of programs that we do jointly, but didn't kind of want to highlight them here just for easy understanding and experience as well in terms of time allocations that we have. And the NHS, I just put some key points about clinical case management, prevention and treatment, antibiotics, antivirals, vaccines, and engagement. I think the key one for me for NHS is a wider prevention roles they play during the COVID-19. And how do we maintain that? How do we enhance that role on prevention? And the public, which is another big partner, I think we have seen it through COVID, preventive measures, or for contact tracing, their contribution for infection prevention control, hand hygiene, including the kind of adhering to the advice that was given through the kind of prophylaxis, treatment, testing, all that. I think engagement with the public is crucial, and that starts at local level. And engagement and partners with wider systems. So it's kind of in a nutshell, giving that a local health protection system in terms of integrated service. I think during COVID, we have seen that it was integrated in real practical way. Next slide, Barbara. So what are the current resources and workforce? Health Protection Service, UKHSA Health Protection North West, and local, we have got 3 sites, Cheshire Merseyside, Greater Manchester, and Cumbria and Lancashire. We provide 24/7 health protection response service, and that is led by consultants and practitioners, surveillance and epidemiology, including our field service colleagues, business support and communication. There are more to it, but I think, again, this is just to highlight the key stuff. Local authorities, obviously directors of public health, consultants in public health and community ICMs and EHS, and the wider local authority staff as well. Again, it was visible during COVID. And system-wide, CHAMPs has been crucial, both pre-COVID, during COVID, and going forward. And collaborative working, we have got obviously the regular TSBH meetings, work groups on health protection, strategy groups, and CPD networking events such as what is happening today. Winter preparedness planning is system-wide as well. What I would say is I think system-wide preparation engagement has to be enhanced post-COVID. I think that is where I think pre-COVID hasn't happened in a way that we wish it to see to happen. Next slide, Barbara. So approach to incident response. This is just to highlight pre-COVID, how do we do it? Obviously, it was health protection teams led, but local authorities supported and NHS also supported in so many ways. And the second one is strong local relationship and engagement. I must say I'm proud of the relationship we had in Cheshire Merseyside and across the North West. We did have really strong local relationship and engagement pre-COVID. During COVID, obviously, that it has enhanced increased joint working. We had Cheshire Merseyside, Cumbria, Lancashire, Greater Manchester, if you like, contact tracing hubs jointly coordinated, convened, and run and delivered. We had shared data systems, which was great. Power BI is a good example. We had also challenging systems like Dynamics, which hasn't worked as well as we expected. And enhanced collaborative working and shared responsibility. I want to emphasize on shared responsibility. I think during COVID, it was a shared responsibility. That is what I think enhanced our integration of joint working. Post-COVID, I think as Jenny mentioned, we have increased resources in health protection teams. We are not feeling it just yet. I think there's a lot of change and COVID is still with us. And hopefully we're going forward, we will see that and we start to feel that. Increased collaboration and joint working involving more stakeholders. I think COVID has shown quite significant players in all areas that we haven't engaged previously. I was kind of looking at IMT notice yesterday and some of the outbreaks we have in supermarkets. We had even security guards in our IMT meetings, which is incredible, and the schools as well. I think they have so many professional groups which we never engage or we never anticipated they will have a role. So that has to be looked at, and all our kind of collaborative work need to be involving more stakeholders that have a role to play. System-wide forward planning. Winter planning is a good example. I think that's happening as we speak, 2020 to 23. And that is, I think, what we need more post-COVID. And monkeypox, as Jenny has highlighted, so there's wider engagement with all sorts of partners and organizations, sector, etc. Next slide, Bob. So going forward, I would like to stress again on the 3 key points: the prepare, respond, and build. So the first thing I would say is more focus at local level. Having a common agenda would help. Clear understanding of clear roles and responsibilities in the local place. I think that we've got a long way to kind of have synergy in what we do. More responsive and efficient service. I'm stressing here on more responsive because if we have clear and joint priorities, I think we could do that. And efficient service, I think has been mentioned about the evidence-based practice. We need to be more challenging and more kind of conscious about the impact on resources of activities that we do, because we have continued to do them without being challenging or without being critical about what the added value or benefit is. Better prepared, forward-looking. I think that is something we need to do more, not just for today. We should be thinking about tomorrow, like winter preparedness is a good example. Sufficient capacity and capability. Obviously, there is a limit to how much resources we could have, but I think we could build on our current existing stuff through training, education, and workforce development, not only in health protection in UKHSA, but the wider system in local authority, in adult social care, in healthcare in general, and outside as well in community settings. So I think that is part of the prepared or build kind of actions that we need to do. And better communication throughout, and that always starts at local level. So I think if we can manage to have a seamless communication from local to regional to national, I think that will go a long way. So I would like to finish that everything we do, we need to look at prepare, respond, and build, and be really critical about the activities that we are doing. I'll stop there, Thara. Thank you.
Excellent, Sam. Thank you so much for landing us again. I mean, there are so many questions and so many sort of ways of potentially addressing this. The one way you said about sufficient capacity and capability, you know, I don't know when the right time is to share my joke, but I will now. How many health protection people does it take to change a light bulb? I actually don't know, but if anyone's got a punchline or a response, you know, you can use the chat facility, but it is quite a tricky one. You know, we're all competing for skilled workforce, but I think we've got to think about how we involve our communities in those solutions, and that worries me, to be honest. There's a really helpful question in the chat. I think it's from, let's have a look. It's from Elspeth about, is that the one about health inequalities? Yeah, so I think Elspeth's asking about the CNM ICS system, Fiona, and how we're going to work together to develop that 5-year strategy for the ICS, how we're going to make it meaningful, so that you're not sitting there going, I'm kind of a little bit lost here. The other reflection, I think, is there is no clear line of sight to the health protection finances at a local level, unless, Fiona, you're telling me there is. I can't see the clear line of sight in my budget line or any other local authority colleagues' budget line. They can speak for themselves beyond April 2023. So yes, it's never been resolved, has it, at a system level, at a local level, who pays for what. But I know, Fiona, we've got some really good success with the monkeypox. Any other thoughts, Fiona, please?
It's a huge question, isn't it? How will we put health protection into our ICS strategy? And a really helpful question, because it's put it into my head now as well to really think about it. Because we need our ICS strategy. But sitting underneath that, we need a clinical strategy as well. And I think it's really important to me anyway, that our clinical strategy drives a lot of the organisational strategy. The responsibility for writing the strategy sits with the health care partnership. And just to get slightly technical, in case any of you don't know, the ICS is made up of 2 boards. Bizarre, but it is. There's the statutory board, which is called the ICB, and then there is the Healthcare Partnership Board. On the Healthcare Partnership Board, it's where every local authority is represented, and where our public health colleagues really put a lot of their contribution in, and that's where our overall strategy will be written. So by virtue of that fact, I think we will have health protection in there. The ICB board itself has 2 local authority chief executives who are partner members on the board, voting members on the board. So that's also a positive. And we are in the process of appointing a director of public health into the ICB senior leadership team. And we haven't written the strategy yet, so when they come in, they will have a significant influence on what goes into that strategy. So thank you for putting it higher up in my thinking as we go into that process. We have to produce it by sort of December, January time, so we are up against it a little bit for all the reasons that I talked about before. But thank you.
Perfect. The Director of Public Health post, it's something that I think our Champs family and Directors of Public Health in Chance Fully support and have helped to shape that. There'll be accountability at local as well as at the ICP level. Another question for you, Fiona, from David Whitfield. In its Cat 1 responder role, aren't you delighted about that? You've got a great opportunity to lead emergency preparedness and collaboration across the patch. So some of the work that Sam mentioned, that we had to work together, you have got this great opportunity to keep our hands together. So we'd be really interested about some of the emerging thinking that you have about how we can work together over the next few months, because they are going to be critical, and we're going to be, it will absolutely pave the way about how we go forward. Any immediate thoughts, Fiona?
Yeah, that category 1 thing is a huge opportunity and a slightly terrifying. So I've recently done the training for the strategic command training, and they showed us all these videos of people having to go up in public inquiries and talk about justify what they'd done. It was terrifying. But we do recognise the opportunity that it brings to work better with our LRFs. We are bringing together the EPRR functions that sat in the 9 CCGs into a centralised team. But we do recognise that with such a huge patch that we will need to face the Cheshire LRF and the Merseyside LRF. And so we are still in the training and development, building our team phase. But our Director of Planning and Performance, Anthony Middleton, is our EPRR accountable person, and he is talking to us about workshops and how we get better at this, or not get better, how we embrace this new challenge and opportunity that's been given to us.
Thanks, Fiona. I remember in peacetime I did my Magic Light Goal Command training. It just coincidentally happened to be with Wiltshire LRF. So when I went down to support the Novichok incidents, as Jenny was obviously very much in the leadership position of, it felt very much like a trusted space. And I think that's what we absolutely need to do in peace-ish time, build those relationships, particularly at the LRF level. So, you know, that is really important, I would say. So thank you for stepping on that. So Sam, there's a question from Elspeth, but also others about the data. You know, there's always data requests. How can we share things in a more timely way so that Directors of Public Health can be assured that there are robust systems in place? It feels like a stuck on the data question, but is Power BI the answer? Is there something else that we should be getting excited about?
It's work in progress, Thara, isn't it? It's quite, I think during COVID, we have been fortunate to have quite a number of national systems working well, especially Power BI, as mentioned. We were able to see data at the same time, and we were able to see more data than even the cases, including contacts and details. At the moment, we are working on the, as you may know, the health protection HP zone system, develop it into SIMS, what we call case and incident management system, which will be a lot better, I would hope, a lot better in terms of sharing data and obviously churning out surveillance data as well at the same time. Could be a solution, but in the meantime, I think what we need at local level is very close engagement and work as much as we can to share data as much as possible within the confidentiality remit that we have. But data is key, as we have seen in this COVID. I think there's no two way about it. Looking at the same data at the same time in those organizations could deliver much more synergy and much more effective response. But when we are on our own, we can't share data. It takes a lot of energy, time, and resources. This is what I was saying earlier on about resources and efficiency. I think data would be one thing I think we should prioritize at local level until national solutions are found for this. And should Jenny or Roberta may have any additional points to make?
Thara, could I just add to that? I think one of the sea changes that I've seen through COVID and since we've become an ICB is our attitude towards data, how we share it and then how we use it. And as a GP, I was brought up on, you are responsible for all that data. You have to protect it. You have to keep it safe. And much more towards you have an obligation to share where it's going to help your patients and your population. So I've seen that change, and then how we use it, the CIFA data that we've used throughout the vaccination programme has given us a real appetite for how we can do that more. So, for example, we've been looking at fuel poverty, trying to track down in Cheshire and Merseyside for this winter, where do our COPD patients who live in poor quality housing and are at most risk of fuel poverty, where are they? And let's prioritise them for the interventions. Let's support their practices more, their GP practices, to go out and help them. So it's a sea change for me.
I think you've helped. Yeah, so Jenny,
sorry, I was just going to come in as well on a sort of national level, because I think there are two areas which contribute to this as well. So I think it is no longer acceptable going forward for people to hang on to data. It's exactly as Fiona's just said. And that applies in other areas. So at national level, there's a lot of work with ONS, and it comes back to the One Health discussion in the chat actually, with ONS, NHSE, UKHSA, about automatically getting safe, confidential systems for sharing data so that we can interrogate them. It doesn't belong to one place. They need to be collated and curated, but it's public data actually for public information and support, and we should all be using it. The other area where I think it's really important, and some get it and some perhaps don't, is on the research agenda. So in universities, for example, academic centres, the historic thing is you do your piece of work, you hang on to it until it's perfect and nobody else gets to see it, and then you publish it. And that is just not what we need for protecting lives. And so I think somehow we need to change that psychology that says the best universities, the best research institute are the ones that publish really early and share. And certainly we're trying to encourage and support that at national level. And we're working with, for example, large numbers of institutes are setting up their own institute for pandemic preparedness. These shouldn't be competitive ones. There's loads of work to be done, and we can have an enabling role. And then in the event of a big national incident, hopefully they will all turn to UKHSA as the enabling link into government. So we've got better traction on loads of bits of research and data to help develop good outcomes.
Thank you. I think so. Mentioning also the opportunities to share data. It is that quality, isn't it? That you sort of, at what point is it quality enough to release? And I know Fiona and I have had some conversations about that quite regularly with Matt and others. I just wanted to sort of focus a little bit on vaccination screening. I'm not sure, I don't know, have we ever got it right locally or nationally or regionally? I think there's been attempts, really strong attempts to do that. But I think the gut feeling is that it always happens better at the subsidiarity, at the lowest, at the kind of the grassroots as possible level that you could actually achieve. Fiona, you're about to take on the Section 7A agreements and all the responsibilities with hardly any staff. Any thoughts, please?
Yeah, so terrified again. Yeah. So my understanding is now that those services will come over to the ICBs in 2024 rather than 23. But I am hearing that group of staff will we will start working, and certainly it's our intention to start working with that group of staff much earlier than that, so that in effect we do it together from now on type approach. But it's a big learning curve, I think, for us locally, and it's really disruptive for the staff. So I do think it is a bit of a risky time, but it's a brilliant opportunity, isn't it? It's a brilliant opportunity to join up the bits of it, because the childhood IMS being over there and us and flu being over there, vaccination programme being, and us doing COVID locally, the frustration, I mean, you've been in the strategic groups with me, the frustration that brings to us is quite significant. So it is an opportunity as well as being a steep learning curve.
And I think the bus, I love the image of the bus. It's been a fantastic way of addressing inequalities. Just want a big shout out to Rachel Musgrave, now DPH in Wigan. She absolutely was our system leader and champion to make sure that you thought inequalities first before you commissioned anything. Jenny, any advice for Fiona?
No, I'm really glad she's going to nurture and love these individuals. I would say, I mean, I was in PCT land when the 2013 changes happened, and I think it's this group of staff who have been moved around so much and who are so important. As I can see people, somebody was commenting on primary childhood immunisations in the chat bar and how they've dropped down, and we need to address that. And just on that one, UKHSA should have that on its priorities list as well when we can get our actual business plan out to support. But they are a group of staff who diligently go out. They make a critical difference between the sort of data we produce at national level, which is robust for what we have, but actually understanding what that means in GP surgeries and local systems. I know we did work in Norfolk, and my immunisation coordinator actually managed, and it wasn't that, you know, to increase our coverage by 5% in one quarter. Now, clearly that isn't right. What she did was found that, which is what we thought we knew, GPs were doing a fabulous job of keeping these immunisation rates up, but the data lags around the system didn't give a true picture. And so it wasn't simply the how you're doing it, it's about getting a clear picture of what's happening. And so, you know, otherwise we'll be sort of reprimanding GPs when they were actually doing a fabulous job and having the wrong image of the protection of our population. So I'm really pleased. I would just say, actually, I have got a meeting coming up, I hope on Monday, at a national end, because we haven't perhaps been involved in some of the start of this and think we need to be. So if you've got any messages locally that you'd like to go in backwards into the top of the NHSE system, do share them with me, because then I can think through those when I'm speaking at a national level as well.
Oh, I have one. Because the way that GP practices are paid for doing their childhood IMS wrongly, the incentives in it are wrong. So you have a time limited period in which to do those immunisations, and once that time has passed, even if you do them, you won't be reimbursed for the cost of doing them. So you lose all incentive to chase down those last few children, and we should change that.
I agree, although that wasn't quite what I meant.
Oh, right, okay. Well, tell them that anyway.
I will say I absolutely agree. So, but what I think is there was talk of a national vaccination strategy, which many will know. I think focus has been very much on what I would call the tail end, which is the NHSE implementation element. And I think we in UKHSA have got a big role to play in what I call the horizon scanning part and what vaccines could we use. But a lot of that work is still ongoing, and I don't think the focus on vaccination is going to go away. So I agree. I think this is a great opportunity. And this conversation shows why it's so important to have the local, national, regional elements all aligned to get the bits in. Hopefully you can see some of us have been where you are and know exactly what the problems are on the ground. So I'll take it.
Okay, so we've got a call to action from Jenny, and I think we'll come up with some suggestions. Sam, I'm sorry, I was going to ask you for the advice. We've run out of time. I'm just going to wrap this session up, say an amazing thank you to the speakers. It's been a really helpful, I think, from some of the chats. It's been very insightful. Really enjoy working with the system players. Jenny, you mentioned the screening IMS kind of people. I'm one of those that's still standing. 2013, Thara, you're the clinical lead for immunisations for London, and you're the commissioning lead. You know, we're still standing, but we might be in different places. So how do we use that energy that we have in the system to focus together on improving the things that need improving and tackling those inequalities? Thank you all. We're going to have a comfort break now. We're going to be back by, right, let's have a look. By 11 o'clock. And you're going to join your respective workshops. You're all going to be randomly allocated, those who are staying. All right, thank you.
Thank you.
Okay, I think we're going to go into session 2. So some people will have dropped off. Hope you've had enough time to, wash your hands thoroughly and dry them. And make yourself a brew. The next session is going to be facilitated by some of our consultant and public health leads who've got a health protection lead role as well from our local authorities. The session will run for about 20 minutes. As I say, you've been randomly allocated, and the whole purpose of this, it'll be explained in the workshop, but it's the question that we're posing is, how is the system going to work at a local level? And how do we ensure that we have the capacity and structure to continue to move to a focus on prevention rather than response? So you're going to be allocated now, and we'll see you back here for precisely 11:22. So thank you all. It'll take a little bit of time to slot you into all of the rooms. The people are piling back in, so thank you for engaging with all of those breakout rooms, and thank you particularly to our facilitators for holding that space. I'm going to ask for 1 minute a summary from each of the facilitators, starting with Sarah, please. Sarah Johnson-Griffiths.
Thank you. 1 minute's going to be really difficult for me. The main issue was that we need to work properly. We need a coherent health protection strategy, and yes, we've spoken about that. But actually, we need something that's that resonates from the national work and is distilled down to the local work. And I think that's something that is missing. We need an open and honest conversation about roles, responsibilities, where things lie. This might come out of the strategy, but we need something now, where the expectations are about who will do what, and that is in terms of response as well as prevention, and in terms of that capacity. There's a few very specific things that we identified as lacking. The ICB and the new systems need to think very strongly about infection control. We've been decimated during the pandemic, but the need has been highlighted. So we need to think about infection control capacity at provider and at community level in terms of TB. And equally, one of the positive things that came out, we've had some great working in terms of data during COVID, but actually we need to make sure we don't lose that coherent collaboration, that sharing, that sort of immediate response to knowing what's going on. We need to make sure that we keep that going, and we need that analytical support.
Brilliant,
and
Sarah. I'm going to stop you now.
All right then, I'll shut up.
Thank you so much, and thank you everyone who was in that workshop. Over to you, Emma. So it's Emma Coffey, please.
Yeah. Hi everyone. We talked a lot about the excellent partnership work and how that's really at the core of good health protection, and the upskilling of staff during pandemic. There was a lot of concern about people generally felt that we're in a period of great transition and change. And feeling that there were risks associated with that, because every part of the system is going through change, and there was a frustration about about, which I'm sure we all feel, about the lack of ability to mature as a system because of the amount of change that happens. There's real concern about the possibility of and the uncertainty around cuts and what that might mean in terms of health protection capacity for and some of our scarce resources were mentioned, including around infection control and environmental health.
Can I stop you there, Emma? I think that's a really helpful place. Thank you, and thank you for everyone in that workshop. Tracy Fleet, please.
Thanks, Tara. Similar things in our group. I mean, I think the key one, Sarah's already said, roles and responsibilities, that clarity for roles and responsibility is key. So the work that Sam talked about earlier is, will be really welcomed when that's available. Funding was obviously also talked about, but so was skill set at local authority level as well. Skill set and priorities for health protection, but also the desire to work on acute health protection at local authority level is likely to be varied. The point was made that we've possibly all managed to retain some capacity from COVID, but that's likely to go within the next 6 to 12 months at the most, and it's unclear what additional local authority capacity there will be beyond that. In terms of the moving from response to prevention, we talked about the fact that health protection is huge, and it's not really clear what really good prevention looks like, certainly at a local authority level, and so some clarity and agreed definitions around some of that, and agreed picture around some of that would be really useful.
That's a really good point where I'm going to pause you. Thanks, Tracy.
Okay.
And the people in that workshop. Charlotte Smith, please.
Everyone. So I think I won't recap on the things. There's a lot of similarity and overlap to what the other presenters have just fed back. So I think the sorts of things that would maybe different in our workshop that we got to were just things about some of the positives. Obviously there was a lot of blurring of roles and confusion about now roles and responsibilities that we need to clarify, but there was also lots of positives in terms of levels of community engagement and really recognizing that grassroots community engagement, and we reached out and we don't want to lose that. So that ability to do that and work at that sort of level. And then the really critical thing I think that came out is that maybe as a system in Cheshire and Merseyside, what the feeling in the room was that maybe what we need to do now is to decide ourselves what we think, work together. What do we think good would look like for us? How would we like to see it? And then we can offer that up to Sam and to UKHSA and get some get some buy-in on that, as well as a sort of way forward for this. I think that was really the critical bit we got to in our room, and that's how we feel we would reorientate ourselves into a sort of working in a more preventative way.
How dare you finish with before I stopped you, Charlotte? Amazing. Thank you. And now Elspeth, and thanks for everyone in that workshop. Elspeth Anwar.
Yeah, hi Tara. We had a really good discussion in our group, and I won't duplicate. I think a lot of the similar themes came up, but one thing we touched on was the workforce, and probably the breadth of the workforce that we need to consider when we're thinking about health protection. So I know, Sam, you put some people on your slide, but I think we could go broader. There was someone in our group who's from environmental health and was talking about the importance of yeah, and it's the scope of the remit of health protection, isn't it? So health protection is not just infectious diseases, it's the environmental threats that we face as well. So it's that, I'm not sure the whole system understands that probably at the moment. So there's probably about that. And then when we think about our wider workforce, maybe there's something for us to do about scoping the breadth of who we're talking about and who we're engaging with. I know it's been mentioned about post-COVID kind of local authority public health teams. I mean, we were saying I'm not aware of the different models that are emerging in the different places. So there's probably some sharing and learning that we could do. But also we're acknowledging that it's quite a difficult time for a lot of our workforce. We're all quite tired. We've been through a lot, and there's cuts going on, as we've mentioned. So we've got to acknowledge that, haven't we, the place that we're in and the place that we're starting from. And that does make prevention difficult, doesn't it? Because we're all firefighting. So I think there's something about whatever we build, we need to acknowledge where we're starting from and have some clear steps forward.
That's a really helpful point, and thanks to the people in the workshop. Finally, Chris McBride.
We had some similar, I think, quite a lot about roles and responsibilities. In terms of some of the, I suppose, maybe additional points, we recognised about, I think, some really good leadership across Cheshire and Merseyside, and really good relationships that have been built. But we also recognised that's a point of strength and potentially a point of weakness as well, in terms of moving forward. So if people change roles, and about making sure that we've got kind of agreed processes, agreed, SOPs, quality standards, so things can continue and we're not relying on individuals always being there. I think the other thing that we kind of recognised was in terms of what do we mean by our system, what's our footprint. So we're looking at Cheshire and Merseyside, we border other areas, so it's also about looking outwards, and we had somebody on from Lancashire and also somebody on from Jersey. And I think the interesting thing is it's not just us who are trying to grapple with these issues and how we're looking at, and I think there is something about, yes, recognising what we need to do as a subsystem, but not forgetting that, this is all across the country. And then the other thing I think is probably just worth mentioning is we also talked about, obviously across the system, there's lots of different organisations, and one of those is, in a local authority, there's a political element to that as well. And how do we get political buy-in to understand the importance of health protection and what we need to do? So, it's not forgetting that as part of the journey.
Perfect. Thank you, Chris. Points well made, and thank you to the workshop. So we've got another little comfort break. It's a 10-minute one this time. And so please, if you can and you'd like to stay, please join us at 11:45 back in this space. All right. Great. Thank you so much. And I really hope that you'll enjoy the next sessions. We've got a fantastic lineup of facilitators and some really meaty topics to choose from. Now, many of you have chosen the workshops that you want to attend. For those who haven't had an opportunity to select, you may end up having been randomly allocated to one. It may be that you think, do you know what, it doesn't matter, I'll just stay. But if you really are unhappy and you want to go to another one, our CHAMP support team will be able to help. But you may end up back in this room and then reallocated, but that will take some time. So what I wanted to make sure is that if you enjoy it, we're going to have a minute's feedback from each session. And we'll see you back here before the close. So, but if you have to duck out before then, please can you make sure you fill in the survey response, because that's really critical for us in terms of our evaluation and next steps. There is also a Menti thing that we're going to put up. So the room leads will describe what's going to happen. You could see the types of sessions that we've got, and any questions your facilitator or the CHAMPS team will be able to address. So thank you, and we'll see you back here for the close, the feedback session at 12:08. Thank you. So thank you. We've still got quite a number of people who've kept with us, so that's great. The purpose of this next session is just to have 1 minute from each of the room facilitator, the lead facilitator. So over to you, Laura Mitchum, around air quality, please. Thank you. Is Laura not?
I think they're still returning, actually, if I just look at the attendees.
Oh, Laura can't unmute.
I can now, thank you.
Good, super.
Thank you. So it was a very short time, so we did our best in that short period. So I think the main points are that it was very difficult to unpick air quality versus local transport, and there does need to be a consideration about how we work, whether it's worked across from the regional approach to air quality, and then that might make that issue a little easier to resolve. It's where we are at the moment, and we're lacking a coordinated approach, and so it's a real need to get that baseline understanding of where we are at the moment, but also where we'd like to be. The need to share learning practices for what works well, what's the challenges, to share journeys for those who've been involved with developing such action plans on air quality across both the local area and the regions. So there was a lot of discussion about how that work could be taken forward, but also engaging the public as well. So a number of the areas haven't actually got an air quality issue with respect to exceeding the air quality standards, but that doesn't mean it isn't an issue. And how is that going to be picked up, and how can we link it in with active travel, active transport, and also the air quality local issues such as indoor air quality, how we can get that on the agenda, but also targeting things like people's heat generation, fuel efficiency in the home, the impact that that has, because it's quite a large source on particulate matter, and considering the wider impacts from the public perspective and how to engage them.
Laura, was there an appetite for a Cheshire and Merseyside air quality collaborative?
So there was already a note about the fact that there is a group which links together and they discuss the air quality from that side. So yes, definitely there's that coordinated plan, so people can discuss what's going well, what the gaps are, identify those gaps, and also from learning outside Cheshire and Merseyside as well. So Greater Manchester's had heavily involvement with Transport for Greater Manchester, looking at how they coordinate planning on air quality going forward. So to learn from outside the region as well, to see what works well.
Brilliant. So I think Cheshire and Merseyside are fortunate to have you, Laura, to help us in this space. And thank you to the people in the workshop. So Tabitha Cavoy around vaccinations and immunisations. Another minute, please.
Oh, hi. So it was a great discussion. I think we felt we needed more time to talk about this topic, because I think it's an interesting one. So I think there was recognition of the current challenges in the system and the fragmentation of the system, but also the leadership, both national and local. But despite that, I think there's a great appetite for people to do well and improve the vaccination and immunization rates. There was a useful discussion about what people have done before and what has worked before. So things like opportunistic vaccinations and things like removing barriers. So there were great examples that are being done local, the family hubs, the use of the bus. And I think people were thinking of how to look at what has worked before and how to take that forward, and sharing of practice around. So I think there's a lot of discussions to be had on what can we use so far that has worked and how can we move that forward, but also recognizing the challenges about the fragmentation of the service.
Thank you so much, colleagues, from that workshop and Tabitha. Next one is using population health management data to drive health protection strategies. Tammy Palmer, please. Another minute.
Hi there. Yes, so it's obviously the problem with population health is that it's massive by its very nature. So it was incredibly challenging in the time that we had. But our discussions, I think the key points that I have down, and I'm happy for Tracy and Melissa to interject here, are that it's around kind of understanding what tools and what data we have already and how to make use of them. So we discussed the potential of using a mapping exercise by analysts to look what's available and what the limitations are of those data, and therefore to kind of identify further tools that we might need. There was a specific kind of discussion around tools available around risk stratification and segmentation, and also what tools were available for predictive analysis. There was also some thoughts around, instead of starting with data, actually, do we start with the problem and then determine kind of what data we have? And I think there's a recognition of how broad this is. And kind of linking into that, we discussed priority groups, we discussed marginalised groups, and also children as a key priority, particularly given the current economy. But there was a recognition that realistically those priority groups will differ depending on what area of health protection it is that we're looking at. And finally, we discussed the importance of aligning with the voluntary sector, particularly around using qualitative data, and recognising that they've got a wealth of data there, but how, and I know it's been brought up previously, but how we share that data between us, and also support the voluntary sector to undertake kind of evaluation that can be used to kind of support what we're doing as well.
Perfect. Thanks, Tanya, really helpful, and to the colleagues in the workshop. Katie Smith, welcome. It's really nice to have a public health registrar speaking at this event. So you're going to talk about what came from the winter preparedness.
I am indeed, and thank you to our group for some excellent discussion and a lot of agreement, which is always nice when you're chairing. So I've just popped in the chat box the 2 questions we were answering, just to give a bit of context to these responses. So the first issue was, we started with the question around winter planning in relation to high-risk settings, and actually the reflection that came out was that we need to consider high-risk people and high-risk individuals as well as settings, particularly those, for example, that were digitally excluded was a good example that was given. And linked to that, build on networks and approaches that were part of our COVID response, such as liaison with workplaces to interact with people through their employers, and liaison with domiciliary care providers, in addition to high-risk buildings and organisations such as care homes. So broadening out what that definition of high risk is, and making sure that individuals and groups that are perhaps more dispersed are also taken into consideration using existing and developing networks. With respect to the second part of our discussion about prevention and management of concurrent incidents, the general response was, yes, we're expecting this to happen, and are cautious and in some ways apprehensive about it, and how can we broach that now. It's about working smartly with individual incidents to maximise our efficiency, but it's also considering the fact that the numbers of these incidents are rapidly increasing. There was a general view that something like the tabletop exercise we're doing for antivirals, a similar approach would be really valid here. And if there was potential for input at the ICB, ICS level to coordinate that across the area rather than repeating it over and over for individual local authorities, recognising timescales are short and everybody's time is busy, but there was a strong recommendation that that would be seen as a really beneficial opportunity to practice how we work these situations and these concurrent incidents well, efficiently, using mutual aid and cross geographical boundaries.
Perfect. Thank you, Katie. And
no problem. Thanks so much to the team again in the room.
Yeah, and the workshop delegates. Moving on to Wiki Dadamis, infection prevention, control and antimicrobial resistance. One of my favourite topics. So Wiki, over to you.
Thank you, Thara. We had a very interesting discussion, acknowledged that infection control is absolutely crucial in reducing infections and thereby reducing the risk of antimicrobial resistance. Our 2 key points were better skill mix and working as one system. So in terms of better skill mix, we acknowledge that infection control is a scarce, small and very elite workforce. It's difficult to recruit, and we need to become better at using infection control for highly complex, high-risk settings and situations, and educating and training up the wider public health workforce to deal with some of the simpler, lower risk situations. We also acknowledge that we have particular gaps in infection control provision over weekends in the community, and that this is something which really needs to be tackled as one health system across Cheshire Merseyside. We need to look at commissioning on a wider footprint, at sharing resources, but we also need to become better at identifying what needs to be done during normal working days and what is urgent and needs to be done at the weekend. And finally, we acknowledge that our environmental health colleagues, who are also a scarce and elite resource, are also very fundamental to helping us with some infection control issues in the community. Thank you, Thara.
Thank you, Vicky, and colleagues in that workshop. Points well, very strongly made. And then finally, Chris McBrien, on what good looks like for health protection locally, please. I think it's Chris, Sam, and Andy. But Chris, are you all right to feedback?
Yeah, that's fine. Yeah, so as you say, we looked at what good looked like for a local health protection system. So we tried to shackle everything that we know and sort of look as what the vision we'd want it to be. I think it echoes some of the conversations from the earlier workshops in terms of the importance of having a clear strategy that really outlines roles and responsibilities so everybody knows what they're doing. I think the other clear thing is about how, you know, at what level do we need to do things? So what needs to be done at a Cheshire Merseyside level, a local level and a national level. And I think taking Sam's 3 pillars of prepare, respond and build, you know, very much that preparedness at a national level, obviously then localised, but then in terms of response often is better done at a local level because we know our own populations, but the preparedness obviously links into that in terms of how we respond, about the importance of reducing duplication, you know, and also in terms of, I think what Sam calls unjustifiable variation as well across our systems and across local areas. And I think the other key thing for me that I think we talked a little bit more about is that kind of, again, looking outwards and what we can learn from other areas. So, you know, Manchester's on a very similar journey. And I think that also comes back to do it once and share. So they're doing deep dives around particular themes. So what can we learn from looking over the board, and what can we share from our side as well? I don't know if Sam wants to add anything, or Andy.
No, I think you have covered all. Thanks, Chris. Thank you.
And thanks also. I think Andy was in the workshop helping as well. So just wanted to say a big thank you to all of the people who just fed back, the people who are facilitating the workshops, scribing, etc. Another big thank you again to our speakers and to our consultants in public health who helped facilitate some of the sessions. It's been a really kind of whistle-stop tour through health protection, but we wanted to ask you to take a few minutes, if you have got time, to just log on with your phones, probably, if you've got one to hand, to menti.com. And you're going to give the passcode, aren't you? It's there. The passcode is 63568038. And in one word, could you describe how you're feeling after today's event? The word cloud will build on that. Just whilst that's happening, I just wanted to identify the next steps. Our chance support team will be working hard to make sure that all of this, you know, that we capture some of the richness of the information that's come. Please fill in the Survey Monkey. We need to know how we can always improve on events like this. We've got a call to action from Jenny to actually look at, you know, she wants some feedback by Monday or she welcomes some feedback about Section 7A programmes. So we'll put some of the insights into the chat that we've had from the chat and the workshop together for Jenny. And we've also potentially got a call for action around air quality and clean air that I think Laura is going to be helpful to us in Cheshire and Merseyside to unpick a bit further. So we've got some really nice things coming up. So thank you, colleagues, for putting that in. They're all coming up. Tell me, Jenny, when we're going to go on to the next one.
Yes, I'll move it to the next slide now.
Yeah, really nice, connected and inspired. And then what's the next question, Jenny? In one word, how would you rate the local health protection working relationships of the different stakeholders? Perhaps we should have done this first question and ended on yeah. Well, all right, great. An interesting challenge and challenging, complex. I think Sam, Fiona, health protection champions, we're not surprised on that, are we? Sam, any reflections?
Yeah, I think challenging is a key word now, isn't it? I think COVID has done quite a lot, but now going to business as usual is how to maintain the same relationships.
So let's keep learning, let's keep developing. I actually opened up my, I don't know if you can see that, but no, you can't. I opened up my learning journal for this event. That's how we're going to get through the next phase. Universal and targeted approaches help to tackle health inequalities, and that's the case for health protection. I think we keep on learning, we keep on developing together. So thank you, everyone. Big round of applause to everyone, and a safe journey for the rest of the afternoon. So thanks especially for the CHAMP support team who pulled this off.